Good afternoon, everyone, and happy December 1st. I hope you are all doing well today. Welcome to the CPHQ prep course. I'm Lindsay Conan with the Flex Grant program, and with us today and for our entire course is Kim Workmeister with Cynosure Health. Just a few things before we get started. This is being recorded. Every session will be recorded, so if you happen to miss one or you want to go back and watch it, they will be sent out at a later time. I did send out the handouts that Kim's going to go over today, so you should all have those, but I can resend them after the session. I think most of you, in fact, all of you probably sent me your book receipt, but this is, well, you can't see it. There we go. This is the book that we will be using. And if you have not sent me your reimbursement yet, please do that now so that I can get that in for you guys. And I think that's about it. So Kim, if you want to go ahead and move over, it's all yours.
All right, thank you so much. And I think, were you going to start? Is it? Oh, it's recording. Yes. So welcome, everyone. I'm so glad that you're all here. I'm excited that I see some familiar faces and names too from some of the other work that we've done, both with some of you were in the Quality and Patient Safety Fellowship last year. Some of you might be in the HQIC program that we're in right now too. And so hopefully you're not, really bored hearing my voice more, but I think we'll have a good time with this, as much of a good time as you can have preparing for an exam. But I promise to make this not as dry as the book. I will say the book, and I have mine right behind me too. The HQuick Solutions book here too it's a fantastic study guide. So absolutely make sure that you're going through the book. And what I'm going to do at the end of each session, so what the plan is for us to go over the part that you're going to read about afterwards. So I want to help to maybe kind of bring a little life to it, and then you'll have the book to go back and you'll get a little more in depth in some places, or there's some that I might just say, just read it because it's not, it's not a huge portion of the exam or anything like that. So that way we'll just help to reinforce it. And then starting with our next session, we'll also include some sample test questions in each one of the sessions here too, so that you just get some practice in not only just, what's the right answer, because there's, generally speaking, on the CPHQ exam, at least two of the answers could absolutely be correct. So it's more about understanding, okay, well, why is this one more correct than the other answer? And so what I want to do is really spend as much time as possible making sure that everyone understands the thinking behind the questions and how to approach the exam. I also know that there, not everyone is going to plan to take the exam the whole time. You might just be here getting some additional quality improvement training, and that's great. This is absolutely there. And what I hope to do is bring some of the, what you see on paper and translate it into what that looks like in real life in healthcare quality. And so just to start, I'll just give you a little bit of background of myself. So I've been a nurse for almost 30 years. And I've been in the hospital level quality improvement realm for probably 20 years of that. I've been at the hospital level. I've been a VP of quality. I've worked my way up in various quality roles. I've also been a nursing director in other areas. And then for about the past, 13 years or so, I've worked for Cynosure Health that I'm with now too, and we do a lot of national consulting and improvement work with lots of hospitals around. So I am a CPHQ. I also have a certification in patient safety, the Certified Professional in Patient Safety, which is a CPPS, which is a similar exam too, but with a slightly different focus. But I'm just thrilled. We don't have enough folks who are trained in quality improvement. And I know if anything that we've learned from the last year and a half is that people continue to leave too. And so I'm so thrilled that you're here and you want to get this training, because we really need new blood when it comes to quality improvement in hospitals. And the way that we've done things for decades is no longer valid. I'm sure every one of you will tell me that too, from at the hospital setting. But the way that things are now, between staffing issues and the influx of patients and the changes in the way that we have to create care for patients, is just different. And so we need this new generation of quality improvement professionals who have a different way of thinking. So don't ever let someone tell you, oh, you haven't been in it very long, or you don't, that's not how we do things. You just answer that with, oh no, this is how I'm going to do it now. And also I'm going to hammer home this point constantly, that you, just because you don't have a title of a director or VP or anything like that, doesn't matter. You are a healthcare leader, no matter what your role is in the hospital. You don't have to be in the quality department. You don't have to have that be one of the many hats that you wear, but you are a healthcare leader, and I'm thrilled that you're here. So with that, I want to make sure that we spend a little bit of time just kind of getting to know who else is in the room with us too, and to also give you just kind of a breakdown of what the course is going to look like. So we have 8 sessions, and those 8 sessions are broken down into the 4 different exam content areas. And so we'll go into that in just a moment. But before we do that, if you wouldn't mind just using the chat box first and type in your name, your title, the organization you're with, and then much more importantly, I think, I don't know, if you weren't in healthcare, what would your dream occupation be and why? And so we'll watch to see what's coming. I'm just going to pull down the chat box real quick so I can see anything that's coming through here. There we go. All right, as people are typing those in, we'll keep talking here too. I also want to make sure that you know this. So each session is slated for an hour. We'll go anywhere from 45 minutes to an hour each time too. So don't be alarmed if you have to leave a little early or something like that. That's fine, and we'll plan to try to make this a little more interactive and fun. So okay, first things first, understanding the CPHQ exam, and there's 4 focus areas for it. The first one is on performance and process improvement. One's on health data analytics. This is the terminology that the National Association for Healthcare Quality uses. Organizational leadership and patient safety. And so we're going to split up these 8 sessions into a part 1 and part 2 of each one of these 4 topic areas. So we're going to start with performance and process improvement today, and just the basic part, the beginning part. And then next time we'll get a little more in depth into a few other parts of the performance and process improvement part. There's some insider tips that I would love for you to know about when it comes to taking the CPHQ exam. First and foremost is, I think the way that this exam is geared, it's really sort of the old school thinking about what a quality professional looks like and does. It's think when you're thinking of exam questions, think, okay, how would someone who was in a quality department answer this? How would a quality department in a hospital organize this? How would a quality director organize this? Even though, just as I'm telling you, that's not the real world in healthcare quality anymore. It's everyone is a quality leader, but for the purposes of the exam, think through, use that kind of lens there too, and you'll see what I mean when we do some of these sample questions. The other 2 real key pieces is when you're answering questions, think about the situation. There's a lot of situational type questions they'll give you, and then you'll have they're all multiple choice answers. Think about that situation through the lens of a systems focus, and we'll be talking about that in the patient safety section. But really what that means is, rather than trying to find out what happened, say in an adverse event when it occurred, the answer is not going to be about that one action that occurred that resulted that we saw that resulted in an adverse event. The answer is going to be something that happened within the larger system that allowed for an error to occur. So if that makes sense, be thinking about the larger system when you're thinking through the answers for the questions. The other one that will be a really good guide for how you think about the questions is the role of a healthcare quality professional. That role isn't to have all of the answers. As a matter of fact, if you see the word facilitate in one of the answers, That's the correct one. The health, according to the CPHQ exam, the role of the healthcare quality, and they also keep healthcare as one word, which I realize now most folks make that two words. Just another example of kind of the older school way of thinking. But the way that they think about it as a quality director or a quality leader is leading folks by facilitating conversation, by bringing data to the table for other folks to see and make decisions, by understanding what's happening out here, knowing that other people need to be educated about and ready for, say, accreditation or other surveys. So that's the role of the healthcare quality professional. The answer will never be the healthcare quality professional has the answer, or the healthcare quality professional does the work. It's the healthcare quality professional facilitates organizational learning and improvement. So I don't know if that helps or not, but you'll see when we start to go through questions that there are a lot of questions like that, where if you think through that lens, it does help a little bit there too. Okay, so, and I also want to make sure that I can't see the chat box when I'm sharing my screen. So Lindsay's going to make sure that if there's questions, if you have something, honestly, I prefer if you just, unmute your line and just shout it out. Just stop me in the middle. I'm trying very hard to not talk really fast, but I tend to do that sometimes too. So feel free to say, Kim, stop, I have a question, and ask it. Or if you'd rather type it in the chat box, by all means do that too. So there's lots of different ways to do it. So
Kim, I have a question.
Yes, good.
How are we using the textbook? Should we just be doing it on our own, or are you going to reference pages?
Oh, so I'm not going to reference pages in each of the sessions, but what I will do is that at the end of each session, I'm going to give you just page numbers that I would like for you to read between now and the next session. And they're going to be directly related to exactly what we're covering in this session today. So there'll be more of a reinforcement, and you'll see, I mean, the book is it's really dry. So I think it's helpful to go, to read it again. And then once we get towards the end too, I'll start to give some suggestions for how to go back and use that book to study too. It doesn't have study questions in it, but what I have found is that simply by really reading again and honing in on the wrap up at the end and the beginning part, those two, so there's like an executive summary and a wrap up, really focusing on what's covered in those two pieces for each section. Tells you exactly what's going to be on the exam, or the main focus areas of the exam. So, how about anybody else? Any other questions before we move on? Okay. All right. So in the performance improvement section, there's a whole lot in there too. And so that goes through things like, and we're only going to do about half of them right today, but the evolution of healthcare quality. Again, you will see that this comes from sort of an old school look at it, because it's all a bunch of old guys in that, and completely disregards, say, some nursing leaders, physician leaders. That's okay. It's important for us to know what we can learn from everyone. And then we'll go over the leadership framework for quality. There's actually ways of looking at leadership, a structure for performance and process improvement. And so this goes back into that. What does it look like to have a quality department that comes up with, how an organization is going to look at performance improvement? We'll talk about the different types of quality monitoring. And this is really relevant to those, when you're getting for organizations that receive money from Medicare, you have to participate in Medicare conditions of participation. And that you also hear it called QAPI when it comes to Medicare. The QAPI pieces of those, that's the quality monitoring that's really important too. So again, that's that focus on the quality department, but we'll get there. We'll also talk about performance improvement tools, and then project management and team leadership for performance improvement. And this is where we really hone in on that fact that the quality leader is the facilitator. They don't have to be the doer. And I use a lot of, I apologize in advance, I use a lot of baseball references. I love baseball. And this is where we think of the quality leader when it comes to a CPHQ framework is the manager. So the manager is not the one playing. The manager is not even the only coach. The manager has the overall structure, kind of the strategic plan for the team. And then under there, you have a pitching coach, you have a catching coach, you have a hitting coach, you have all these other coaches. Those would be your department directors. Those would be others who are around your organization who are responsible for other pieces of the puzzle. And then you have the players, the ones who are actually doing the work too, our frontline staff members. So that's kind of what it looks like when we talk about who a quality leader is. Think manager, facilitator, strategic planning there too. And then we'll talk a little bit about strategic planning and how we align goals to advance quality. And so let's go through some of these quality professional roles. When it comes to planning, this is where, and I'm trying to highlight these words that you'll see a lot on the exam. So in planning, that's where the professional is going to assist with establishing priorities. You don't make them, but you assist with them. They'll facilitate the development of action plans. They're not the ones developing the action plans, but they're working with the other coaches to develop some action plans. They assist in the selection of, say, evidence-based practices, or the selection of the different types of activities that make up an organization's entire quality improvement portfolio. They do things like use prioritization matrix. We'll talk about that, and because everything's a priority. So a quality professional assists in deciding what's actually the priority right now. They identify opportunities to collaborate. This is kind of newer. I mean, it isn't in real life, not newer, but it's a newer focus for the CPHQ exam in the last, say, 10 years, that collaboration is a big deal. It used to be that we didn't really think about collaborating with others in quality improvement, which is, unfortunately, I was part of that era back then. We just never did. It was, you did your stuff and you didn't want to share it with anyone else, and you didn't want anyone else to find out anything that was happening in your organization. Quality professionals now know that we need to collaborate at any time that we can, and there's lots of opportunities for it. So the CPHQ role would be to help to identify which ones would be the biggest benefit for the organization. And then finally, in assisting with the identification of improvement champions. We'll spend more time talking about how we identify champions for improvement, but basically that is someone who is competent to do the work that we're trying to improve. So it's someone that's currently clinically competent if it's a clinical activity. It's someone who is respected by his or her peers. It's someone who is interested in something, in whatever it is that we're trying to improve, and someone who's not afraid to talk to their peers. So an improvement champion does not have to be someone with an official leadership role. That can be someone who's, that can be it's best if it can be a frontline staff person. That's not always possible, but it's best if we can find that. So keep those things in mind. And then the other aspect of the quality professional's role, that's an implementation and evaluation. So again, I'm just using the words here that really show up in the correct answers for the test here. And that's in establishing teams and roles. So you're, again, the manager, the leader, but you're not actually running everything. So the quality professional would say, hey, we need an adverse drug event team, an improvement team here. And I've identified that, we've seen data that we have an issue that we need to improve. So I'm going to go to all of my specialists. So I'm going to bring in a pharmacist. I'm going to bring in nursing. I'm going to bring in, whoever it is. So you'll establish that team and help them to get started. You might sit in on the teams too, but you're not the one making the decisions for what comes next. Also, the quality professional role is in monitoring. When it comes to these teams, you'll monitor project timelines, how effective the team is. We'll talk a little bit about there's something called Bruce Tuckman's team development stages, which shows up frequently in the exam. I think last year was the first year I heard back from someone that took the exam and said they didn't have that question on it. So, oh, good, but we'll talk about it when we get to that too. Also, so the quality professional evaluating compliance with requirements for public reporting. This is the real basic in the quality department stuff. So are we reviewing everything we're supposed to be reviewing? Are those things going to the right people or being reviewed in, say, a medical staff committee, or is it being reviewed somewhere else? Are we reporting to CMS the kinds, if we're required to report for public reporting, or if we're accredited or licensing, what are the various things that we need to be doing? The quality professional has the oversight to evaluate whether or not that's being done. The quality professional isn't the one actually doing it, sometimes, but not always. But they have that oversight. And then finally, in this section, coordination. So they coordinate risk management activities too. So this is another part where it's, again, through the lens of the old school. You have a whole department, you're lucky enough to have a whole department that's the quality department, and risk management is part of that. They really are different things, but it's important that a quality professional understands what risk management activities are comprised of. And those are, there's a variety of them. There will be maybe one question, maybe two on risk management activities on the test. So we won't focus on that much, but it'll be in the reading. But really, it's just more around the questions would be more around setting up a system for making sure that adverse events are reported. And if you see that there's a low volume of events being reported, a quality professional would understand, okay, so we need to put something in place that makes it easier for events to be reported. So if we have a system, and maybe it means we need to, that quality professional would be responsible for helping to evaluate different types of systems for reporting. So not making the ultimate decision, but evaluating them. I know this stuff's pretty dry here too. I promise we'll get into a little bit more. That's not quite so boring, but then the other part of the quality professional's role is in education and training. So again, you're the manager, you're helping making sure that everybody else is following along. Everyone else understands their role and what we should be doing when it comes to quality improvement. So that the quality professional is responsible for designing, and this is one place where they will provide the actual quality improvement training for an organization. So your organizations all have some methodology that you generally use when it comes to quality improvement. It doesn't matter what methodology you use, they really all basically end up being the same. We'll talk about them in the next session, but we'll go into the small details in the differences. But the quality professional would be the one who, say, in new employee orientation, is responsible for providing that training, and then maybe once a year, once every couple of years, does that training for managers and directors or for anyone else. It helps others to understand how we do the work of improvement. Then they will also be evaluating the effectiveness of that training. And then finally, in the other side of education and training, that's preparing for surveys. So whatever kinds of surveys you have for your organization, it is the quality professional's role to help to develop that training. They won't necessarily be the one to give it, but they will be the ones to decide, okay, so we know that we have a survey coming, within the next 3 months. And when we've been looking at our data, when we've been collecting data to see if we're in compliance for various things, we see that here's an area where we have some issues. So I want to make sure that our staff understands what we did as a result of finding those deficiencies and what we've done now, and then help them to understand the kinds of questions that they might be asked by a surveyor. So it's really that kind of prep that is the responsibility of the quality professional. And then I think this is the last one in there. Yeah, it is. Okay, so finally then the last piece of the role here is communication. So again, facilitation and communication, not the doing, which is kind of nice, but we know that's not realistic because we're all doers also. So the quality professional is going to help to facilitate conversations with members of your organization regarding quality issues. So any of those issues that come up, it's the quality professional who will help to be part of those conversations, help to kind of bring them all together, because if this person's hearing different issues from different people, they have a good global view then of exactly what's happening when it comes to quality issues in the organization. They might be the ones to write performance improvement reports, or maybe not. They might just be the one that's kind of facilitating it for other folks to do. But any reporting around performance improvement is going to come through the quality professional. And then they would disseminate performance improvement information throughout the organization. So maybe your organization is set up where there's multiple, maybe you're a large organization, you have lots of departments and they all have their own performance improvement planning and the data that they share that goes through this quality professional. Most smaller hospitals do not, and it's the same 1 to 3 people that are doing this. So understanding too that the CPHQ exam kind of thinks of this in terms of what does an average hospital look like in America? And I don't know what that is because there's so many different sizes, but think of it as like, what would a mid-range, what would this look like in a hospital with 100 beds? So if that helps to kind of frame the way that they're probably thinking of the questions. They also help to facilitate communication with accreditation and licensing bodies. They lead and facilitate change. And then just even down to the basics, just organizing meeting materials for quality improvement things. And that's really just comes from a point of understanding the main focus and wanting to lead and facilitate this conversation in the right direction for improvement. So big giant overview there of what the folks at the National Association for Healthcare Quality who give the CPHQ exam, their role of their version of what a quality professional does. So I would be surprised if there's anyone on the call today who that sounds exactly like what the quality professional does in your organization. There's real life, there's a lot of differences too. So I hope to bring kind of some of the differences here too, so that we get a better understanding of that. And the first piece of it actually is I'm going to show you just a short video. I apologize because it's also me in the video, which seems so dumb that you have to listen to my voice, but the visuals in it go really well. And I just want to set the stage for what quality improvement looks like in the real world and how it works in a way, how we can really look to quality improvement as a way to build up everyone too. And so I want to talk about what we might be able to learn about quality improvement from fireflies. So I'm going to take it here, and I think I have to share my sound. There it goes. Okay.
So what can we learn about quality improvement from fireflies? Is there anything similar about those two things? I'll tell you there is. And I'll tell you who found out about it. It's a story of a biologist named Hugh Smith, who in 1935 was on an educational expedition in Southeast Asia. He was deep in the recesses of a mangrove forest on a river by himself in a boat right at dusk. It was very hot and sticky on a hot summer evening. The nocturnal animals were just starting to come out. And as he silently floated along the river, all of a sudden, the entire mangrove forest lit up like it had just been struck by lightning. And then it went dark again. And then it happened again and went dark again. And then again and again and again. He was shocked at what he was seeing, and he realized that what he was seeing was actually fireflies all lighting up together. It wasn't lightning, but it sure seemed like it. As he continued studying, he found out that the reason lightning bugs or fireflies light up is that the males light up to attract the females. And normally, deep in the recesses of a mangrove forest, a male has about a 3% chance of attracting a female. But when all of the male fireflies light up in sync together over and over again, they increase their chances for all of them to attract females by 83%. It's incredible. And that really does speak to what we do in quality improvement. We compete for patients for business, to patients in our beds. We want them to choose us, but we certainly don't compete with our fellow hospital organizations or other healthcare organizations or other departments when it comes to learning how to get better together. So I want you to keep that in your mind as you go through these modules and think about how we can always be thinking about working together so that together as we light up, we're going to also help not only each other improve, we're going to help ourselves to improve.
All right. Okay, so with that was obviously when I had dyed my hair dark, but we really the idea behind this is that nowadays we don't have to hide what's happening in our organizations. We used to think that way, and quality improvement is not a competitive sport. It's a team sport, and we really need to help all of the fireflies. The more fireflies we have lighting up, the better chance we have for all of us to make improvements. That's why all of these collaborative activities that we have are so successful. It's not because we have an expert who wrote an article that was based on years of research that we all got to read that article and then suddenly poof we've figured out the answer to anything else we're trying to improve. No, it's because we've been able to talk to peers, other people who are actually doing the same work, who are facing the exact same challenges, and they have something simple that they've implemented. It's one thing to get, say, well, you have to implement that bundle, and then that's all that's important. Well, that's great, but tell me how you do that in a critical access hospital with 3 beds as compared to a university hospital with 800 beds. There's differences there. We really need to talk with our peers and learn from them these tips and tricks. That's where the beauty is in quality improvement. And so that's not part of the exam, but it's what true quality professionals know now. And so I want to make sure that you are part of that team and you understand that this is what we're really all about. And that's why we're all here together. And that's why it's so important that we do these kinds of things together. Yeah.
Sorry, is that video in Click or would
that
you
is in Click? Yeah,
here,
let me just real quickly, I will type this in because
okay.
I want everyone to sorry, you have to hear me typing. I know there are people that can type and talk at the same time. I am not that person. Okay, so Click is for those of you that are part of the HQuick program. You've probably heard of it, and those that you haven't, you're all invited to join it. So Cynosure has something called the Cynosure Learning Improvement Connection, which is Click. And in Click, it's totally free. You just have to register with your name and your email and your organization. And you'll find in there there's a course that where this video came from. It's a course called the Building Blocks of Quality and Patient Safety, which is a real just brief kind of foundational level look at quality and patient safety, but it's a nice review too if you wanted to go through some of those. We have some basics of infection prevention. We have courses on readmissions, sepsis, adverse drug events, pressure injuries, you name it. We have courses in there, and we're always adding new ones there too. And the way that it works is every course is broken into really small modules that are most of them are video modules just like this. That's about the longest video that we have. They're very short. Some of them are written pieces there too. Some of them have tools that you can download. For all of the clinical patient safety topic areas, we have something called discovery tools, which you can download, and you use those as kind of a cross between a gap analysis tool and a tracer to just in a really brief period of time say, okay, here's a process that I know from looking at 5 to 10 medical records that we are not reliably following in our organization. So lots of stuff in there. Please, this is another benefit of being part of this group too. So by all means, please join Click and use anything you can in there, and give us suggestions for how we could improve, other things that can be added there too. So, but with that, so again, also the other piece, that the other really key thing in quality improvement is to know that you should never have to invent something on your own or reinvent the wheel at any time. There is probably something out there that's already been created that you can use, and hopefully that you'll find some of those things and Click too. We call it stealing shamelessly. It's not stealing, it's there for everyone. There's no reason to create something new. And so where a lot of that comes from is from this evolution of healthcare quality. And this is where there will definitely be some questions, really more about the people and kind of the overall general era that they were in. And so this first era of healthcare quality, there are a few people that are part of this. So the first one is Walter Schuhart. And it's not important that you remember everything about them. It's just that Walter Schuhart was the first person to think about the PDSA or PDCA cycle. We'll talk about that. Then Edwards Deming. Edwards Deming, you'll hear about Deming all the time. That's probably one of the most well-known names as the father of quality improvement. He's the one that brought a statistical process control. Joseph Juran talked about the relationship between quality and cost containment. Think early days of what value-based purchasing was, but before anything like that. And then finally, Ishikawa. If you have participated in a root cause analysis, you have probably used an Ishikawa or a fishbone diagram too. And what's similar about all of these folks is that they were not in healthcare. All of the lessons that we have learned from them came from manufacturing. So some from Western Electric in the US, and then much of it came from the Toyota system in Japan. So these folks took what they were learning together and then brought it to manufacturing and learned how to make improvement from a manufacturing standpoint, and then brought that back. We started to utilize that in healthcare. A key thing is to really know, though, is that while these are all fantastic tools, we use them all the time, healthcare is not manufacturing. So I think always keep that in the back of your mind too. You'll also see when we talk about patient safety, healthcare should be like the airline industry. Well, healthcare isn't. We're not an airplane, but there are some similarities. So that's a common theme to hear, is that we have similarities that we've taken from other industries and tried to take the best of those and then translate those to how that results in improvement. Okay, so that was the first era, those folks. And then we get to the second era where we have Donna Bedian, and then the Joint Commission started. So Donna Bedian came up with something, you've probably heard this phrase before and maybe didn't know who it was attributed to. So Donna Bedian is the one who came up with structure plus process equals outcome. And what that means is we create the outcome that we create by putting in the structure, the way that it's built, and the processes that go in that system. Those two are however those are put together is the outcome that we're going to get. So when we're not getting the outcome that we are hoping for, it's time to go back to look at the structure and the process, because something in there, all systems are perfectly created to have the outcome that they create. So if it's not great, let's go back and let's see and let's look at it. It's probably more of a process. Something within that system has been designed so that it's not creating the outcome that we want. Then the third era, this is where we had someone like Don Berwick. This is where the Institute for Healthcare Improvement, or the IHI, came along. This is where James Batalden, who actually is the person that said that phrase I just said, every system is perfectly designed to get the results it gets. That we started thinking through more than just quality assurance and the manufacturing and pulling out the defect to, wow, how can we look at a whole system? How can we look at a whole system and see all of the different points that interact together to create that outcome? And where can we create some changes in those systems to make improvement? And when in our next session, we'll talk about the model for improvement and other improvement methodologies. And we'll say over and over again that, all change or all improvement requires change, but not all change is improvement. So that's what this is getting at, that every system is perfectly designed to get the results it gets. So just because you made a change doesn't mean it's going to result in an improvement. And so that's where this third era, we started really learning about how to make changes that actually result in improvement. This is where this learning collaborative approach came from then too, that we need to be together, not just, in our own little silo. So that's where these things started happening. And now that takes us to where we are now. And this is the fourth era, where patients are at the center. And this is so, I'm so glad that we are finally in a place now where this is what's so key. For a very long time, and I will tell you, it's when I was a quality director too, we never thought of patients as members of our care team. we really thought of patients as, we were like the parent, and no, you don't need to hear about that. This isn't, this is above your pay grade. We know what's best. We'll just do what we say. That old parental do as I say, not what I do, or because I said so. Now we've learned that actually, if we don't have our patients and their family members as a member of our care team, uh, we're going to make mistakes, and we're not going to have the full picture. And so we really, you've seen across the country how we really have changed, and we have started focusing on integrating patients and families into care. Maybe it's something as simple as doing bedside rounds. Now, again, the last, almost 2 years now are different. We didn't have the families at the bedside. And I will tell you that we've seen there are many reports that have come out now in the last few months that tell us that we had significantly higher numbers of hospital-acquired infections. We had significantly higher rates of sepsis. We had significantly higher rates of mortality in non-COVID patients. There is something to be said for having someone else at the bedside and really partnering with them to have that one set of eyes that sees everything coming in and out, as opposed to each of us coming in just at the individual time and just having our little piece of the puzzle. The more that we can really meaningfully partner with our patients and their family members or caregivers, the better for all of us. And like I said, I came from a time when that wasn't the case. And as a matter of fact, I even remember being asked to have a patient join a quality improvement meeting. And I said, or a former patient, I said, what? No, they can't listen into that stuff. They can't hear that. And now it's common. We know that actually getting their perspective, we're not going to have someone that just had a horrible experience and want them to come in and try to sue us. It's not that. It's having someone just who's been in a situation of being in the bed, and having a different framework to work with to help us make those changes. And that's what the fourth era, that's what this patients at the center is about now. And it's a good one. So, okay, we'll spend just the last few minutes just talking about the structure for performance and process improvement. And this is really into this is what the quality department does. This is the QAPI plan, for lack of a better word. So some key pieces for the exam will be this approach to quality monitoring. So what is quality monitoring? How do we do it? And what do we need to be monitoring? So quality monitoring can be done in a variety of ways. It can be done by retrospective chart audits. It can be done through what we call quality assurance audits. So think temperature checks in the refrigerators. That's a quality assurance audit. They can be done in newer methods now. It's something that we call measurevention. And that's where you're doing some real time while the patient is still in-house, looking to see, did we, it might be on just the documentation side. We have those clinical documentation audits. Did we document everything we're supposed to do? But also maybe it's in person and it's actually at the bedside. And that's where we're seeing are we doing what we said we were doing? A really common one for this one is for the prevention of VTE, or venous thromboembolism. For VTE prevention, there are a few key drivers for improvement. One is that every patient would have an assessment that's based on their risk, and from that risk-based assessment, that's where the preventative measures are ordered. And those would be anywhere from nothing if it's a mobile patient who has no other pre-existing things, or maybe this is someone who needs medication like a Lovenox plus has those SCDs, those sequential compression devices on their legs. So maybe for that patient, we look and we see in the medical record that, yep, this patient is at a higher risk, and we have ordered all of those things. Then we go into the patient's room and we see that the SCDs are not on the patient's legs, they're on the floor. We see that the assessment said the patient is completely bedridden, but the patient is actually walking around. So that's what measurevention of that real-time kind of quality monitoring looks like. And then we have process audits. You probably see this on a regular basis for, if you're looking at, say, bundle, bundle compliance. So did we do everything we said we were going to do prior to inserting a central line? That's what process audits look like. And then we'll finish today then on the different types of quality monitoring that are required. These will come up on the exam. They're basically just kind of memorize what kinds of things do we need to be monitoring. So medication use. We have to have some form in an organization for monitoring the use of medications. So maybe that's looking at high alert medications. Maybe that's looking at different types of adverse events that are medication related. Maybe it's looking at antibiotic use, the number of any kind of events related to opioids. There's all kinds of ways to do medication use. Blood usage is another one. This is one where unless you're in the quality department or in the blood bank or lab, you would never, this isn't like an overall quality thing, but it's important for the CPHQ exam to know that one of the types of monitoring that is required for hospitals is that you look at the type of, what blood is being used, how often are we giving blood? What are the parameters for when to give blood? Are we following that? Are we going back and reviewing? Are we wasting blood? The different types of blood that we're using. So all of that goes into a blood usage monitoring. Restraints too, and not just behavioral health, but that includes posy vests, that includes wrist restraints. We have to be monitoring restraint use and making sure that we're following whatever the state or federal guidelines are for restraints. Operative and invasive. This is around surgical care. So this is where we look at anesthesia use. This is where this also does include moderate sedation generally too, for the time where it's not anesthesia, but it's twilight, moderate sedation. Do we have complications from certain kinds of surgeries? Do we have foreign bodies that have been left behind? Anything like that happens, mortalities shortly following an operative case. All of those things go into operative and invasive. And then CPR, this is another one that is required. And this is actually a really helpful one, especially if it's combined, if you have a rapid response team. So the required monitoring is just, how many times how many codes do we have? What's the, who responds to the code? What was going on with the patient at the time and the outcome? And we use that, if that's combined with how many times a rapid response team is called, that what happened after that, and is there did the number of codes decrease, then the CPR, the number of code blues decrease? That's a good thing. So this is another area where it's required monitoring, but we can use that in other ways for quality improvement. And then morbidity and mortality might be called M&M. Again, old terminology, but this is every organization should be reviewing every single mortality. That doesn't mean that every single mortality has to go through a peer review process or has to have a full everything. Not all mortalities are unexpected. So what, unfortunately, we are all going to die at some point. And what organizations do, the important piece for the quality professional is to know that my organization has a process that is set up by the medical staff to review mortalities. And your medical staff may say, as long as these 5 criteria are met, we don't need to review that further. But anything else, we'll do some sort of review. And then for morbidity refers to those serious complications that occur. So a common one in OB, a morbidity eval, would be for a patient who delivered and then had a severe postpartum hemorrhage. And it required blood usage. It required maybe even a transfer to a higher level of care, something like that requires additional care as a result of some sort of complication. That's a morbidity. So those are always monitored too. And it just comes up in survey. A surveyor will say, can you show me where this has been reviewed by the right people in your organization? The right people would be probably medical staff, probably a quality improvement committee, maybe it would go up to all the way up to the governing board reviews all of these things, just in different levels of review. And then also infection prevention and surveillance. We all have to have some methodology for doing surveillance and then for reporting that out too. And then even medical records. This one is just, do the medical records have everything they're supposed to have? So this is where you'll hear about, they haven't signed their HMPs yet. They haven't done this. They haven't they haven't closed, they haven't signed everything within 30 days of discharge. All of those things have to be in place for medical records. So a lot of this is just boring stuff, but it is what it is. And then finally, peer review. And for those of you that aren't familiar with what peer review is, so physicians are generally not employed by hospitals. Sometimes they're employed by the hospitals, but they aren't always. But they are still, even if they're employed, they're considered independent practitioners. And so with that, that means that me as a nurse cannot look at the way that care was provided by a physician and then make a true judgment as to whether or not that care was adequate. That needs to come by someone else that is of the same clinical competence. So peer review is physicians reviewing physicians, and every organization has their medical staff sets up monitoring guidelines for peer review. So generally it's done by department. Each medical staff kind of department will have specific items that they use for peer review. And then organizations have all kinds of different ways of doing it. Some have a set peer review committee and that committee reviews everything. Some do peer review initially in their own individual committee. So anesthesia only reviews anesthesia and whatnot. There's no right way to do it. Whatever works best for your organization is how it works. The key for a quality professional for this is that there are some legal protections about peer review too. So it's not discoverable in court if it's done following the right guidelines. So the peer review information isn't public, and it might go to the board, but it would go in a I don't want to call it redacted format, but more of a simplified format than what the actual medical staff looks like. Medical staff needs to see everything, but the rest of the organization does need to know that there is peer review happening and kind of the outcomes of it. And so the last thing that I think I have for today is this performance improvement plan. And this is I said early on that a quality professional helps the organization to prioritize improvement activities. And there are lots of ways to do that. This is just one example of what we call a prioritization matrix. This one comes from AHRQ because it's just based on what we call the PSIs, the patient safety indicators. And so AHRQ has developed this one because there's a whole bunch of PSIs, but not every single one of them is a priority for hospitals. So they've worked out a system so that you look and see, okay, based on our data for the PSI-3, the pressure injury, this is an old photo because it still says pressure ulcer, but what is our rate? So you would put that in, and then what's the national benchmark rate? Okay, if you're below the national benchmark, well, already at section 1 in blue, we probably, it's not a priority. But if you're still over the national, then you go over to, okay, let's look at section 2, and this is kind of the cost piece of this. How much is the annual cost of this event to our organization? And we know that a stage 3 and above pressure injury, that costs us real financial dollars, in addition to what's more important, what it costs a patient in their care. But that's just one more aspect. So you can get the idea that this one is set up with a variety of factors. You can set up a prioritization matrix any way that makes sense for your organization. What's important is just that your performance improvement plan for your organization must have a method to prioritize improvement and monitoring. So just an example, it's just one, and I think the key takeaway is there's no wrong way to do this. It's just important to do it. So with that was a lot of talking by me, and I apologize for all of that talking. Next, so with our next month, we're going to go through then the different quality improvement methods. We're going to talk about how to lead quality improvement projects, again, being the facilitator. We're going to talk about organizational preparation for quality improvement. So whether or not that's your actual job here right now, that's okay, just for the exam, what you need to know. And it's same with accreditation, licensing readiness. And then we'll do some sample exam questions. That's a lot more fun, I think, when we can do that too. I don't think I have a video for the next one, but that's okay. Or I might even. I do have a video. So a video, and it's not my voice, and we have sample questions, which will be better. And then between now and then, so we're meeting every 2 weeks, except over Christmas. So what I would like for you to do is take the HQ Solutions book. And so we didn't go in order of, I think that one starts, I forget what the first section generally is in here. It's organizational leadership. We started with performance and process improvement. that actually makes more sense to me for this. So that's why we started with this. So you're going to just read the part that we went through, and that's pages 134 to 163. It's great nighttime reading. So just skim it. But more importantly, before we meet next week, find out how your organization monitors quality improvement and shares that information at all levels. So I'm not going to ask you to report out or anything, but this is a good way to start to think through, how do others do this? So find out what gets reported to the board, who reports it, and is there a difference between what gets reported to the board and what gets reported to, if you have a quality improvement committee, what gets reported to our quality council, what gets reported in individual departments, and how does everyone in the organization get to know about that? Is there a way to share all of the findings that we have from quality improvement? And if not, then hey, there's your next role as your quality leader in your organization, is finding a way to make sure this information goes out to others. So that is it. Any questions or comments or anything that I can answer about the exam today?
If you have any questions for Kim, you can pop them in the chat or just unmute yourself. While you're thinking of that, I did have quite a few comments in the chat about some people not receiving the slides. And so I did write back, but the way we will communicate for this course is through that Google Groups email. So you need to make sure that it's not blocked by your facility server so that you'll be able to get the handouts, the recording, anything like that. So I did try to catch everybody that had commented and get the slides to you right away so that you could follow along, but just for after this, when I send the recording, to just make sure that that's maybe not being blocked.
And that's the Google group is kind of nice. It's a little listserv. I know we used it for the Quality and Patient Safety Fellowship too, but it's a great way for us to maybe just communicate in between too. So send questions or send, hey, what do you think about this? Or would this be on the test? And we'll just get a chance to really get to know your peers too, who are going to be taking this exam with you. So,
and we don't have anything in the chat, Kim. So I think
okay.
We can
all right then. Well, thank you. Well, my email's here. If there's anything that you think of later, to send me an email. Those of you that worked with me during the Quality Patient Safety Fellowship too, I love talking about this. And if there is anything that I can do to support you, you can reach out to me at any time, and I will be thrilled to talk with you. So, thank you again for today, and we'll talk in 2 weeks.
Yep, we'll see you on the 15th, everybody, at 1 o'clock again.
Thank you. Bye.
Bye.